Good afternoon, and welcome to our presentation entitled Childhood Trauma and Chronic/Traumatic Stress. I'm Dionne Coker, a psychologist and associate professor in the Department of Psychiatry at Georgetown University, MedStar Georgetown University Hospital, and I'm joined by my colleague.
Hi, everybody. I'm Matt Biel. I am a child and adolescent psychiatrist. I'm a professor of psychiatry and pediatrics, also at Georgetown University Medical Center with Dionne.
Thank you, Matt. So today we're going to be covering childhood trauma and traumatic stress. And what we have planned is to talk about trauma-informed care. We'll share some definitions. We'll do a quick refresher on adverse childhood experiences, and then we'll delve into military-based trauma and its specific impact on children. And we'll wrap up our presentation with some resources that might be useful in your practice.
Great. So I'll get us started. And I'm just going to give a bit of background about trauma and adversity and implications as we think about clinical care, particularly in primary care pediatrics. So, as many of you know, trauma and adversity are endemic childhood experiences. They're very, very common experiences in childhood. 25% of American children experience a traumatic event before 16 years old. And defining a traumatic event as an event that is a discrete event in which a child or adolescent feels an overwhelming sense of fear and threat, the potential for loss of life, and a sense of being out of control, overwhelmed, not able to handle the situation that they're confronting. Now, nearly 50% of people, thanks, Dionne, nearly 50% of American children experience an adverse childhood experience before 18 years old. Dionne's going to talk more about how we define ACEs in a little bit. ACEs are different than trauma. These are more often everyday experiences that are part of a child's environment, part of their family environment, their community environment, and Dionne will give us some more background there. But we want to distinguish between trauma and ACEs. They're not exactly the same thing. So trauma and adversity have some similarities, though. They're both forms of extreme stress. Trauma is an extreme stress that occurs, again, for a discrete period of time. So trauma may be an exposure to a natural disaster or to an incident of violence in the home or in the community, to a terrible motor vehicle accident, to a terrorist attack or a shooting. So some kind of discrete event, again, with overwhelming fear and anxiety and threat of loss of life. Adversity, again, are these more daily experiences. But both trauma and adversity can precipitate mental health symptoms in children, and they may increase the risk of chronic mental health symptoms in kids who already have a mental health diagnosis. So kids who didn't previously have depression or anxiety or some other mental health diagnosis, those symptoms can be precipitated by a trauma or by chronic adversity. And kids who have pre-existing depression, anxiety, some other kind of mental health condition, those symptoms can be worsened after exposure to a trauma or after a chronic experience of adversity. The specific impacts of trauma or adversity depend on factors. So not every child responds in the same way. It depends on individual traits in the child's personality and temperament and other characteristics in the child, specific features of the extreme stress, how long did it last, how severe was it, and really importantly, how did the adults in the child's life respond? When children are surrounded by very capable adults who are able to buffer the effect of the trauma or adversity on the child, children generally do much better. And when kids do not have the benefit of a buffering of stress or adversity by adults, they tend to suffer more from the results of the trauma or adversity. Next slide, please. So many of you have probably heard about the idea of trauma-informed care in healthcare settings. And I just want to give a few backgrounds about what we mean by trauma-informed care. So trauma-informed care is an approach to healthcare that includes a couple of things. One is a general level of knowledge, of awareness that trauma and adversity are common, as we've said, that they're often invisible. When a child or adolescent shows up in our clinic, we don't necessarily know what their trauma history is. In fact, we usually don't know. They're not necessarily bearing the scars. Sometimes kids are bearing physical scars. They're oftentimes not bearing physical scars of experiences of trauma or adversity that they may have had. And we need to know as healthcare providers that experiences of trauma or chronic adversity can significantly impact that child's health, both physical health and mental health. And we need to have an appreciation that experiences of trauma can have short-term effects, so the immediate aftermath of a trauma, can have medium-term effects, so in the weeks and months after a trauma, there can be symptoms and health effects, and then long-term sequelae. So long-term health outcomes, again, both in physical health and mental health, are impacted by experiences of trauma or adversity that go unaddressed. There are things that we can do as healthcare providers and as healthcare leaders to make our places of care more trauma informed. So at an organizational level, we can train our staff, and that includes training our clinicians, but also includes training medical support staff, and includes training administrative and front office staff about the fact that trauma is invisible, that it's common, and that it affects the way that people feel and behave. And then secondly, we can think about the processes that we have for patients. An example being that we don't want to create processes for patients where they're asked questions about their history, particularly about histories of trauma, again and again and again through an intake process into clinical care. We need to be aware of the fact that these are difficult conversations for kids and families to have. They're critical conversations to have in order for us to give informed care, but we need to think about the processes that we put patients through so that they are not put through a process that unintentionally, but very meaningfully, may re-traumatize or negatively affect them psychologically as part of the healthcare process. On a clinical level, we need to think about screening. So what are the processes that we do in our clinic to screen for trauma and to screen for chronic adversity? What are the trainings that we can do for our clinicians in evidence-based approaches in primary care to both screen for and address trauma in the moment in a clinical encounter? And then thirdly, what are the collaborations that we can set up, the referral partnerships and the consultation partnerships that we can set up with behavioral healthcare providers and other entities to complement care so that we're able to effectively respond to trauma or adversity when we identify it. A couple of definitions. I gave a version of this at the outset, but just to remind everyone, trauma is a complex emotional and behavioral response to a terrible event, a threatening event, such as an accident, assault, or natural disaster. This is really important. Trauma does not universally lead to psychopathology. 20% of people who experience a trauma develop post-traumatic stress disorder. So that, of course, means that 80% do not develop PTSD. Many individuals who experience trauma then experience recovery, and in fact, may often experience post-traumatic growth. The experience of trauma can actually be a source of strength, a source of feelings of resilience, a source of personal identity as someone who can survive difficult things and grow from them. So the story of trauma is not just a story of people developing severe psychopathology and suffering. There certainly is a lot of suffering involved with trauma, but many people, in fact, the majority of people do not experience PTSD and oftentimes experience recovery and growth. And for children, the folks that we work with, support from adults is the single most important long-term prognostic factor. Those adults obviously start with their parents, but include healthcare providers, educators, and other adults in their lives. And then finally, in terms of thinking about stress and how we talk about stress clinically, I like to break stress down into three categories. There's good stress. That's brief, manageable stress that's buffered by capable adults. So good stress might be something that is like moving to a new town. I know that happens quite a lot for military families. It might be facing an academic challenge. It might be trying out for a sports team and not making the team. These are the experiences that help us all to grow up, to steel ourselves against difficulty, to find strength and resilience, to lean on our communities and our families. These are manageable experiences, and when they're buffered by capable adults, children grow from those experiences. Then there's bad stress. Bad stress is a stress that is brief, but it's overwhelming, and it's buffered by capable adults. So this is something that you wouldn't wish to happen to any child. This may be a child who loses a parent, a child who experiences bullying, a child who experiences some kind of adversity in childhood that we wouldn't hope for any child to have to experience, but we know that these things happen in life. But if adults are there to help the kid make it through that experience, the kids can do just fine. It doesn't end up being damaging or traumatic on a long-term basis. Then we get to the final category of toxic stress. Toxic stress is the kind of stress that we most have to worry about in healthcare, because toxic stress is the kind of stress that is associated with long-term poor mental and physical health outcomes. Toxic stress is recurrent experiences of stress, not brief, but recurrent, overwhelming, so the kid is not able to cope with it on their own, and the kid does not have capable adults who are buffering that experience. So this may be a child, for example, who's witnessing violence in their community, and there's no adult talking to them about what's going on and how they can feel safe. It may be a child who's experiencing domestic violence at home, and it's happening day after day, week after week, month after month, and no one is helping that child to feel safe. No one's making sure that that violence stops and helps the child understand what's happened. Those experiences of toxic stress are the ones we have to be most concerned about in healthcare, the ones that we have to develop systems to address and to intervene on behalf of kids. So, Dionne, I think I'll pass it over to you now.
Perfect. Thanks, Matt, for that great overview. And as Matt mentioned earlier, um, we can't really have this discussion without talking about ACEs. And I know many of you are probably aware of adverse childhood experiences and the literature around ACEs. However, we just wanted to give a quick review just to ground us a little bit before we begin to transition into what this looks like in military families. And ACEs are traumatic events that occur during childhood, typically between the ages of 0 to 17 years. And the initial study, which was conducted by the CDC and Kaiser, identified 10, excuse me, 10 ACEs, which were primarily focused on adversities in the home. And that was then further delineated to include three categories, which included abuse, neglect, and household dysfunction. And typically, the higher the ACE score, the worse the health outcomes. And those outcomes, as Matt just mentioned, could lead to lasting negative effects on health, well being, and opportunity. So we really need to be aware of ACEs as they relate to trauma because some of these exposures, if they are chronic and ongoing, can lead to trauma that will then need to be addressed within the mental health field. And then shifting gears here now to talk more about the context of the military and military families, we thought it would be important to talk about some of the types of military trauma that service members experience. And some of the common ones are combat related deployments, survivor's guilt, where service members may deploy with their peers and then their peers may not return, or they may be severely injured. And that results in the development of what's called survivor's guilt. And then that is what service members are then struggling with upon their return from a combat related deployment. Another type of military trauma is what's called moral injury. And that is where a service member may be asked to perform a task or to do something within their scope of work, but that is also not aligned with their morals and values. And then that creates what's called moral injury that they then have to deal with. And finally, another common type of trauma that is experienced in the military is military sexual trauma, and that can happen to all military members. And when we think about military trauma within the context of childhood traumatic exposures, some of the common ones that you need to be aware of and consider are parents with post traumatic stress disorder, or parents who are experiencing post traumatic stress disorder, or depressive disorders, traumatic brain injuries, or substance use disorders, which are all disorders that are common with service members who are engaged in combat related deployment, particularly multiple deployments. We have to focus on areas where a child may experience neglect, child maltreatment, child abuse, and exposure to intimate partner violence or domestic violence. And when we think about this trajectory of factors that increase risk of trauma reaction, some of the things to consider would be pre existing health and mental health conditions, parents who are reserve personnel, and that relates to situations where parents are called up to service and their children are used to them being at home and then all of a sudden they're gone, they're just gone, and there's typically not much time for the families to prepare, and their children are left wondering where's their parent, and where are they, how long are they going to be away, and you just never know how long you're going to be away. And so that can cause a trauma reaction in children because the parents just disappear, particularly with reserve personnel as opposed to active personnel. And then parents with multiple deployments. That can be very trying on families and on youth because you never know how your parent or caregiver is going to return, particularly with regard to combat related deployments. They could come back injured. They could come back with some of those mental health disorders that I just shared, PTSD, a depressive disorder, a substance use disorder, a TBI. And that totally changes the manner in which they interact with their family members, particularly their children and spouses. And so, parents who have multiple deployments, that could really increase the risk for trauma reactions in children, depending upon how they present when they return from those deployments. Another area to consider is living far from military communities, because, and Matt mentioned this a lot in his talk about support. When you live far away from military communities, there's that level of commonality, knowledge about what military families experience. You don't have that commonality when you don't live close to military communities. So you feel isolated in those experiences, and that can also lead to increased trauma reactions in young people. And then finally, thinking more about living in single parent families where one parent is deployed. And so that has could have a traumatic effect on children because you're in a single parent family, your other parent or caregiver is no longer in the home, but then they're also deployed. And that comes with its own set of issues that young people and families have to deal with. And so that can then also lead to increased risk and trauma reactions. And when we're thinking specifically about the impact of trauma on children who are in military families, some of the things to consider would be children's resistance to the service member returning home. Again, as I mentioned from the previous slide, children, they just don't know how that caregiver or parent is going to return home and what condition they're going to be in, if they're going to be missing maybe some limbs, if they're going to be isolated from the family, if they're going to be abusive, if they're going to be neglectful. Children just don't know. So they may develop this resistance to the service member returning home. Or they may view the non military parent as the sole caregiver, which then could cause the service member to feel as though they have no place in the home, which could then lead to a number of issues within the family when they just don't feel like they are needed. And then we have this whole issue of hidden helpers. And that's where children become adultified. They begin to take on caregiver roles and they just have to grow up quicker than they normally would had they not been in military families where parents are deployed or they're experiencing some of these traumatic experiences. So the hidden helpers is something that I think we all really need to be aware of in the way in which that impacts the lives of young children. And then these are just some symptoms that you might want to be aware of when you're working with military families and children, and some of the symptoms that you may need to identify. Anxiety, and with younger children, that may look like temper tantrums, all the way through depressed moods, sadness, irritability, adjustment issues, academic problems, and then children who just excessively worry about everything. So if you're able to screen and identify some of these symptoms, you may be able to also identify if that young person is experiencing some trauma and then be able to explore that more to provide necessary assistance to that family. And then some of these risk and protective factors, and Matt also, some of this is redundant, so I'm not going to spend much time on this slide. But when we think about risk and protective factors, all of these bullets could be either, it could be risk factors or protective factors. And we want to think about the severity of the trauma. How close are the young people to the trauma? We have to think about proximity issues. How do caregivers respond to the trauma? Because how they respond often informs how their children respond. Is there a prior history of trauma, which Matt mentioned in his talk? And then family and community factors. And this really boils down to the level and amount of support that families have. when they're dealing with traumatic experiences or trauma. What type of support do they have within the family, and what type of support do they have within the community? And that sort of leads back to the point that I made about families who live far away from military communities. That support from parents, from caregivers, from family, from extended family, from their local communities is really important in addressing trauma and the impact of trauma on military families. And then we're going to wrap up today just sharing two resources that we think are very useful for you all as um, providers. One is the Child Traumatic Stress Care Process Model. And this model is really important because it gives you resources to use to work with youth between the ages of 0 to 5, which goes through one process with the SEEK questionnaire. And then there's a whole roadmap that you can use to intervene to help youth who are in that early childhood phase. And then there's a different process that is outlined for youth between the ages of 6 to 18 years with a different type of screening process and tool, and a different roadmap to help intervene with those with youth that are more in the adolescent form of development. And so this is a great resource that you can tap into as you're caring for or treating military families who are experiencing trauma. And then the last resource that we'd like to share is this Find a Therapist resource, which will help you find a certified therapist who has expertise in trauma focused CBT. And there's you can do a search with regard to your area, with regard you can put in a specific provider's name, the location. It's a very user friendly tool that will help you find therapists that can work with the families that you're working with. So just wanted to share those two resources that might be very useful in your practice, and then here's some resources and references also that you may use that and find helpful as you continue to work in this area. And we will wrap up there, and happy to take any questions or comments.